Although there are many oral health problems, this lesson is going to discuss the most common oral cavity disorders. The oral cavity or mouth is where digestion of food begins. The teeth tear, grind, and crush food into small particles to promote swallowing. The oral cavity disorders can severely affect nutrition and oxygenation, as well as speech, body image, and self-esteem. So we're going to talk about some of these disorders. These disorders can include stomitis, oral candidiasis, tumors, premalignant lesions, and oral cancers. So stomitis is an inflammation within the oral cavity, such as canker sores. It's classified by primary or secondary. Primary are non-infectious, such as herpes simplex and traumatic ulcers. Secondaries result from infection by opportunistic viruses, fungi, or bacteria in the immunocompromised patient. Stomitis can result from infections, allergies, vitamin deficiency, and systemic disease, and irritants such as tobacco and alcohol. Certain foods can trigger an allergic response. These are coffee, potatoes, cheese, nuts, citrus fruits, and gluten. Interventions are targeted towards health promotion through careful oral hygiene and food selection. Common secondary causes are yeast. Then we have tumors. They can be benign, precancerous, or cancerous. It can impair swallowing, chewing, speaking, and often painful. Premalignant lesions include leukoplakia and erythroplakia. Leukoplakia presents as a slowly developing changes in the oral mucous membranes, causing thickened, white, firmly attached patches. The patches appear slightly raised and sharply rounded. A small percentage may become cancerous. It's result from mechanical factors that cause long-term oral mucous membrane irritation. Tobacco products have also been implicated. Most common oral lesions among adults. Oral hairy leukoplakia, also known as OHL, can be an early manifestation of HIV disease and is highly correlated with progression from HIV infection to AIDS. OHL is not associated with HIV and often seen in people over the age of 40. OHL is also associated with Epstein-Barr virus. Erythroplakia is a red, velvety mucosal lesion on surface of oral mucosa. This is considered precancerous. It's commonly found on the floor of the mouth, tongue, palate, and the mandibular mucosa. It presents as a red, velvety mucosal lesion on the surface of the oral mucosa. There are more malignant changes in erythroplakia than in leukoplakia. It is analyzed by biopsy. It's most commonly found on the floor of the mouth, tongue, palate, and mandibular mucosa, like earlier discussed. Then we have oral cancer. Prevention of oral cancer include minimizing sun and tanning bed exposures, tobacco cessation, and decreasing alcohol intake. A new mouth rinse has been developed that could diagnose many cases of oral cancer in its early stages. The rinse works by identifying CD44. It's a protein tumor biomarker on the surface of the healthy tissue that increases with oral cancer. Okay, we're going to talk in a little bit more into detail about oral cancer. In the past decade, dentists and physicians have begun systematically screening their patients for oral cancer. This is done through the lymph nodes of the cervical region. Okay, so first I'm going to discuss squamous cell carcinoma. More than 90% of oral cancers are squamous cell carcinoma. It begins on the surface of the epithelium. The mucosal erythroplasia is the earliest sign of oral carcinoma. Oral lesions that appear as red, raised, eroded areas are suspicious for cancer. A lesion that does not heal within 2 weeks or a lump or thickening in the cheek is a symptom that warrants further assessment. Major risk factors are increasing age, tobacco use, and alcohol use. There are some occupations at risk: textile workers, coal and metal workers, and plumbers. Additional factors are sun exposure, poor nutritional habits, poor oral hygiene, and infection with HPV-16 and certain occupations. Then we have basal cell carcinoma. This is the second most common type of oral cancer. It occurs primarily on the lips. It looks like a raised scab. It's often asymptomatic. Over time develops as a pearly border. It does not metastasize but can aggressively involve the skin of the face. Major risk factor is excessive sun exposure. Then we have Kaposi sarcoma. This is a malignant lesion in blood vessels. It's painless, appears as a raised purple nodule or plaque. The most common site in the mouth is the hard palate. It's also found on gums, tongue, tonsils, and it's often associated with AIDS. So let's talk about collaborative care. There is surgical excision, radiation, chemotherapy, and multimodal therapy. Think about what equipment you're going to need. That's right, a pen light, a tongue blade, a 2x2 to lift the tongue. Explain your methods and technique. Think about what position you're going to put the patient in. That's correct, high Fowler's. May use a toluidine blue solution that can be applied to the oral lesions to check for malignancy. Definitive diagnosis is done through biopsy. You don't want to use touthettes because they don't adequately control bacterial plaque and can dry out the oral mucosa. They may have a chemo brush. This is an ultra-soft toothbrush if the platelet count falls below 40,000. Treatment for oral cavity lesions includes surgical excision, radiation, and chemotherapy. The multimodal therapy is the most costly. Nursing interventions will include restoring and maintaining oral health. If a great deal of tumor is present or there are copious secretions, then maintaining an open airway is the primary focus. Okay, so now we're going to talk about the surgical management aspect of it. This is a surgical removal or cryotherapy, and such as carbon dioxide laser and then photodynamic therapy. You want to make sure to review instructions for patients undergoing large surgical resections that are on page 1198 of your textbook. The extent of surgery depends on the size and location of the tumor invasion into the bone, and whether there has been metastasis to the neck or lymph nodes. There may be a possible temporary or permanent tracheostomy placed. Protect the incision from mechanical damage and infection. You want to make sure to relieve pain. You want to promote nutrition, including fluid intake, and always make sure there is a patent airway. You want to facilitate communication. Keep the head of the bed up at least 30 degrees. They may be in PO status that has been ordered, and then when taking fluids, assess for aspiration or leakage. They may need thickener to prevent aspiration. You want to make sure that they are consulting with a speech therapist, and they may have body image changes that can cause depression. Okay, so now I'm going to talk about disorders of the salivary glands. We have acute sialidinitis. This is an inflammation of the salivary gland. It can be caused by infectious agents, irradiation, or immunologic disorders. The disorder most commonly affects the parotid or submandibular gland. Being in PO for an extended period of time can lead to the development of this. Drugs such as phenothiazines and tetracyclines can trigger an episode. Infectious causes include CMV, Staph aureus, Staph pyogenes, and Strep pneumoniae, and also E. coli. Untreated infection of the salivary glands can evolve into abscesses, which can rupture and spread infection into the tissues of the neck and the mediastinum. This may be a complication of radiation therapy. Sjögren's syndrome is characterized by chronic salivary gland enlargement and inflammation. Post-radiation sialidinitis, exposure of the glands to radiation, produces xerostomia within 24 hours. This may be temporary or permanent. Salivary gland tumors are rare, painless, and slow-growing. They may involve facial nerves and paralysis. Nursing care is centered around IV fluids, and then finding and treating the underlying cause and increase the flow of saliva. Small sips of water during treatment. After treatment, saliva substitutes may be provided. You want to make sure to do neuroassessments. Treatment for tumors includes surgical excision followed by radiation. There is a parotidectomy and a submandibular gland removal that patients are at risk for weakness and loss of function of facial nerve because of the facial nerve is often damaged during the surgery. There are certain questions you need to ask during the assessment. Can they wrinkle their brow? Can they raise their eyebrows? Can they squeeze and hold eyes shut while nurse tries to open them? Can they wrinkle their nose? Can they pucker their lips? Can they puff out their cheeks? Or can they grimace or smile? This concludes the lesson of care of patients with GI alterations part 1. If you have any questions related to the lesson content, contact the instructor.